My topic today is Retrograde CTO PCI, a current appraisal. I have nothing to disclose. As you know, CTO remains one of the most challenging subsets of PCI. The success rate with anti-grade approach is around 65 to 70%. Retrograde approach improves the success rate up to 95%. The era of retrograde CTO PCI began with direct true lumen puncture, kissing wire, cart, and reverse cart. Reverse cart is the most dominant retrograde technique. Reverse cart has been iterated into several subtypes to improve procedural success and efficiency. As you can see, this is the evolution of CTO PCI. It starts with basic anti-grade wiring, then follows advanced anti-grade I-bus guided wiring. After that, wire-based anti-grade dissection and re-entry, then rudimentary retrograde such as kissing wire technique, true lumen puncture, then advanced retrograde with cart, I-bus guided reverse cart and its types. It is followed by advanced ADR, that is device based, and the global approach is when we put everything all together. So this is the CTO team from Toyohashi Heart Center in 2005, and this article depicts my journey through retrograde CTO PCI since 2005. As you know, at least 30% of the CTO would require retrograde. As you can see, the difficult anatomy, the proximal cap ambiguity in RCA CTO. So what are the indication of retrograde approach? It is indicated in failed antigrade approach, plus aortosteal lesion, ambiguous proximal cap, CTO with bifurcation at distal cap, CTO with severe proximal tortuosity or calcification, CTO with diffuse disease or poorly visible distal vessels. It needs to have some toolkit in cath lab. So these are retrograde short guide catheter, collateral crossing wire such as Sion Black, Shuho 3, knuckling wire such as Pilot 200, Gladius Mongo, penetration wire, Gaia Next 2 and 3, Conquest Pro 12 and Hornet 12. Externalization wire such as RG3, R350, Viper, microcatheters such as Corsair, Caravelle, Mamba Flex and so on. It also requires I-bus and tools for complication. We need to have ideal collateral channel that includes clear connection between recipient and donor vessel. It should be of side branch size and there should not be any tortuosity or bifurcation. As you can see, collateral grade 1 and grade 2 are good for retrograde approach. And tortuosity also impacts crossing of the collateral. Severe tortuosity is bad for retrograde crossing. Also branching spot, non-branching collaterals are better for retrograde crossing, where branched collaterals, they will impede retrograde crossing. We must avoid boom separate collateral, as you can see. So here crossing is very, very difficult, almost impossible. These are the steps of retrograde approach, and it starts with dual coronary angiography. Septal collaterals are preferred to epicardial. Then collaterals, we reach the collaterals with the help of microcatheter. Then collaterals are crossed with the help of collateral crossing wires. And then we need to cross the CTO, and the CTO is crossed depending upon the position of antigrade and retrograde wire, and finally wire is externalized, then CTO is treated antigradely. These are the types of retrograde technique. The first is direct true lumen puncture, where retrograde wire directly crosses the proximal true lumen. It is successful in less than 20% of the cases, and it is applicable in short segment CTO. Kissing wire, when the retrograde wire is used as a marker and then antigrade wire crosses into distal true lumen. Cart is antigrade navigation of the wire into distal true lumen following retrograde ballooning, and reverse cut is retrograde navigation of the wire into proximal true lumen following antigrade ballooning. So this is cut, that is antigrade navigation of the wire after retrograde ballooning. You can see the RCA CTO, the proximal cap is ambiguous, and so retrograde approach was used. This is the retrograde wiring, as you can see. And this case was done in 2005, and the retrograde wire we had used choice PT. This is the retrograde balloon, and then with that antigrade wire crossing and then stunting with overlapping strands. However, there are certain pitfalls of CART, such as difficulty in negotiating a retrograde balloon, extension of the subintimal space to the proximal true lumen of the CTO might cause a fatal event, empirical estimation of the retrograde balloon size, and unpredictable procedural time. Reverse CAT is better than CAT as it is reproducible, safer, quicker, more effective, and there is easier gear handling. As you can see, this is the reverse CAT. The antigrade and retrograde wire overlap, and then inflation of the antigrade balloon to create a common subintimal space. And through this common subintimal space, there is retrograde navigation of the guide wire into the proximal true lumen. And then, depending upon the wire position, both antigrade and retrograde wire may be both intraplaque and both are in subintimal, and one is intraplaque and another is subintimal. Depending upon the condition, retrograde approach is embarked upon. So this is the iteration of the reverse CAT. The reverse CAT had been modified to make it simpler. So the current types are conventional reverse CAT, assisted reverse CAT such as IVUS, stent facilitated and mother-child, then contemporary or direct reverse CAT, shifted or extended reverse CAT. So this is conventional reverse CAT. As you can see, there is a longitudinal overlap of antigrade and retrograde wire. Antigrade balloon is moved towards the point of overlap. Antigrade balloon is inflated, and there is common subintimal space created, and retrograde wire is entered through the common subintimal space, finally into the true lumen. What are the highlights of conventional reverse CAT? It suits essentially any CTO except those without retrograde option. It may be primary retrograde or bailout after antigrade failure. Retrograde wire usually starts with the intermediate load and knuckling compatible. Adequate wire overlapping and balloon size needed for passive wire migration and connection. It accommodates techniques such as knuckling, IVUS guidance for troubleshooting when failed to create common subintimal space. This is the cartoon of contemporary or directed reverse CAT. Antigrade, as you can see, antigrade preparation, antigrade wire through the CTO, and small balloon is moved towards the tip of the antigrade wire. Then retrograde wire is moved towards the antigrade balloon, and then retrograde wire towards the inflated antigrade balloon, and retrograde wire finally into the space and then into the true lumen. And this is the publication of contemporary reverse CAT in 2015. Now, why antigrade preparation? Wire control is easier and safer in antigrade compared to retrograde. It finds suitable point for penetration of the retrograde wire, the point without dense fibrous tissue and calcification. It decides antigrade balloon size for reverse CAT. So this is a proximal RCA CTO, antigrade preparation, and then reverse CAT with smaller balloon, and then retrograde Gaia enters into proximal true lumen and final result. So contemporary reverse CAT not successful in some situations such as lesion less than 15 millimeter, or when the lesion is ambiguous, tortuous CTO, heavy calcification, long unplugged CTO. Then we need to use IVUS in this situation, and some cases may require traditional cut. So regarding conventional and reverse cut and contemporary, there are certain differences, such as basic CTO wiring is antegrade or retrograde in conventional and antegrade in contemporary. Knuckling is suitable in conventional, it is unsuitable in contemporary. Antegrade balloon size is large in conventional, small in contemporary. Retrograde guide wire low to intermediate in conventional. There are Gaia series of guide wire in contemporary. Retrograde wire control often imprecise in conventional, precise and intentional in primary. That is contemporary. On indications of conventional reverse cut or CTO requiring bilateral wiring, calcific and tortuous anatomy, whereas for contemporary, there should be clear proximal cap occlusion course without heavy calcification or tortuosity. However, there are still small number of cases where reverse cut fails or takes a long time. Failed reverse cut accounts for 30% of the failure in retrograde approach. There is a need to reverse cut procedure quicker, more reliable and more efficient. This is the example of extended and reverse cut. There is extension of the intimal or subintimal dissection beyond the CTO segment. It is usually useful in cases where antegrade preparation or retrograde cap penetration is not feasible. You can see this is proximal ostial CTO, ostial archer CTO. Reverse cut is attempted at one place, however, it is not successful. Then site of reverse cut is changed, then final result. How about mother-child reverse cut? Sometimes guide extension catheter may be deployed into antegradely created subintimal space for retrograde guide wire navigation. It may be removed or repositioned if there is a connection of failure. So this is CTO of anomalous proximal RCA, bilateral wiring, then antegrade with microcatheter, antegrade wiring, then retrograde knuckle. So deployment of guide catheter extension antegradely and retrograde wire externalization and stenting antegradely, and this is the final result. So the difficulties of reverse cut are connecting the spaces, such as wire too far apart or wires not in the same space, navigating the proximal CTO vessel. When wires are too far apart, contemporary reverse cut may be attempted. So that involves antegrade preparation, maximize wire control, virgin territory wiring, and wiring towards the end of the balloon rather than the side. When contemporary reverse cut not possible, it may need a knuckle in very long CTO and calcified CTO. Short CTO, there is no space to work in occlusion, so I was guiding wiring and sometimes ADR is recommended. Wires not in the same space, get both antegrade and retrograde wires subintimal with the help of knuckle, still cannot connect, may require IVAS, bigger balloon, and move somewhere else in the vessel. So this is the global algorithm, and as per the anatomy, we need to select retrograde approach depending upon the anatomy. Anatomy dictates the strategy. However, bilateral wiring is done in most of the cases and the procedure is undertaken as per the anatomy. And these are the various publications of retrograde done by me. So my conclusion is CTO anatomy plays a pivotal role in deciding PCI strategy. CTO PCI has been revolutionized with development of retrograde technique. The reverse cut is the predominant retrograde strategy employed currently, as it is easier, predictable, quicker, and safer. The current iteration of the reverse cut, such as conventional, contemporary, and extended reverse cut, would further facilitate its adoption with more efficacy and safety. Guide extension catheters and IVAS may assist the technique further. Thank you for your kind attention.